On this week's episode, I was privileged to grab a post-call coffee and spend some time chatting with Dr. Rob Kieser at Father Coffee in Kramerville. Dr. Rob is well known and well loved on social media platforms such as Instagram for his witty and fresh take on all things from coffee to studying medicine to having too many Woolworths shopping bags. He has also previously been quite vocal about his support for completing ComServe in rural districts, adopting the right attitude to your junior doctor years, and not being pressured into specializing, leading some to even label him the anti-specialist. Besides being able to share from his experiences in internship and ComServe, I thought he would be a great guest on the podcast to present a fresh take on having a life and career outside of specializing in medicine, and to share what life is like outside of that career trajectory. You can follow Dr. Rob Kieser on Instagram on @RobKieser, if you don't already, that is. And without further ado, here is Dr. Rob Kieser. Welcome to the Dr. Coffee Podcast, Dr. Rob Kieser.
Thanks so much. It's wonderful to be here. Great to chat a bit and just share some things.
And great to share some nice coffee. We're here at Father Coffee in Kramerville, a wonderful space with a good industrial look. Thanks so much for making time on a Saturday morning to just answer some questions. And I'm looking forward to getting your perspective on a number of things. Right off the bat, what I always do with all our guests is I ask you about where you did your training in medicine and where you did your junior doctor type, so your internship and ComServe. So let's begin there.
Fantastic, yeah. So I trained in Pretoria, at the University of Pretoria, so did my undergrad over there. It was a good 6 years. And that was sort of my starting point. From there, we moved through to Johannesburg. Joburg was then for internship, where I did my 2 years at Barra. And then, at this point, I'm not sure how much exactly to delve into that, because I think that's an hour of conversation on its own, but I'll let you lead there. And then after Barra, we decided to go completely off the grid, and we went to rural Free State, but like deep rural Free State, southern border of the Free State, little district hospital called Mbekweni. And we did our year there. And then since then, we've walked an interesting path as well, a bit of an unconventional path. And we found our way back up to Gauteng, got married, and then have done a combination of private work as well as moving back into state. Well, when I say we, me and my wife.
I was about to say, before we diagnose you with personality disorder, you keep on saying we. I think you met your wife during medical school.
Absolutely, yeah. So we were familiar since first year, good friends since first year. So there was a nice casual foundation there. Got to know each other well over the 4 years that we studied together, and then in fourth year we started dating.
Who made the first move?
I think it was probably me. Not always well reciprocated, but I was persistent, so we got there in the end. So whenever I say we are, it's just natural for me to refer to us as a family unit.
Fantastic.
And that's why I say we a lot of the planning that went into internship and ComServe selections and all of that, also centered around us two being able to work together.
So Barrow was your first choice?
Yeah, so it's a good question. We had to be quite strategic. When we approached the end of sixth year medicine, a lot of talk is happening around planning for internship and what your options are, and also around that conversation is the lack of guarantee that you have. So we, number one, heard good things about Barra. Obviously, it's dependent on who you speak to.
Yes.
But we did a lot of digging around, speaking to people who are currently there or who were currently there.
From Pretoria or from UP,
yeah.
Had you had any exposure of actual clinical experience at Barra, or was it all, like you say, from people telling you what it is?
So it's a really good question. So none at all. Barra was this very abstract concept. And more often than not, it's portrayed in a negative light. So there's often a bit of apprehension when you hear about Barra. So the only exposure we got as students in our undergrad was Califong, Steve Biko, the CHCs at Mamelodi, very much Pretoria hospitals and clinics. And that's why we were so intentional about reaching out to people who worked at Barra or who were there currently to see what is it like right now. I mean, it's useless to ask someone what's a hospital like if they haven't been there within a year of you asking them. because things change so much.
Yeah.
So
That's very good. So that's
yeah.
the advice you should have for this year's graduating class is
I've got lots of
ask
advice. I've got lots of advice for them.
we'll dig into it as much as we can in the
Yeah.
short time that we have. So, so Barrow for internship. You
Yeah.
mentioned a place that I can't even pronounce for Comsud.
Yeah, Mbekweni.
Mbekweni. And where in South Africa is that?
So if you take the map of South Africa, you've got Free State, and then the southern border of the Free State, where I think it borders with Eastern Cape, is
Like Sarip Dam area.
yes, exactly there.
Okay.
Exactly there. Harip is one of the places we went to go braai, for example, on a weekend.
Sure.
Yeah, so it's exactly that district, and it's in a little town called Zastron.
Okay.
And the hospital, like we said, now is called Mbekweni. Very small. I can't remember the exact amount of beds. I think we were like 40 beds, 40 odd beds. Yeah, maybe a little bit more than that if we stretched our capacity.
Wow.
Very much a district level hospital, but because of the lack of other hospitals in the area, we often had to deal with emergencies that should have probably been treated at a higher level facility.
But of course, those higher facilities are 300 k's away. So
Precisely. So you're looking at a minimum of 2.5 hours away to get to Pelanomi, which was our main referral center, and I mean the big challenge was obstetrics. It was a massive challenge because you've got your high risk obstetric patients who can't always get to the hospital in time when they complicate, and when you have prem births and prem complications. Getting those to the hospital is such a challenge because you'll have issues like the helipad doesn't have landing lights, so they can't land at night, right?
Yeah.
So now you've got to keep the baby alive until the next day. Okay, so you're frantic to manage the level of case that you're dealing with there.
especially as a MO, like you're fresh out of internship and you've done internship at Barrow where there's all this amazing facilities.
And support, and
Yes.
senior support.
Yes.
As much as people want to complain about Barra, the one consistent thing there is always a senior. I mean, we can have a separate conversation about what the senior support is like, but there is always a senior that you can ask for advice, who can give advice.
Yeah.
Once you're gone and you're in the sticks, it's you. It's
Was
on
it
you.
something you thought of before choosing that for
Yes,
Comsud?
definitely. Because Barra is, even though you're working incredibly hard, you're still relatively sheltered in terms of responsibility and personal volition because you've got such a structured hierarchy over there, right? So whenever you're managing a patient, you have the option to always go to your regular consultant for further advice, and they will generally see the patients with you as well, depending on what rotation you're in. We wanted to develop independent decision making. And
that was in your arc. You were like, this is what we need to get.
Yes.
Yeah.
You're not going to stand on your own 2 feet unless you put yourself in an environment where there's no one else to tell you what to do, and you need to think now what is in the best interest of this patient. I mean, obviously, you're not all knowing, and you're going to phone out for advice and management plans and so on. But at the end of the day, I mean, it was us, and that really factored into us picking Mbekweni because it was a Comserve-run hospital.
Were there any other hospitals that you knew of that would offer a similar kind of experience? Because following this podcast, I can imagine there's going to be 200 people all putting Mbekweni down.
Right.
So what other hospitals were on your radar for a similar kind of experience?
I mean, to be completely honest with you, I've forgotten a lot of our other options. I actually, it was a while ago, to be honest.
No worries.
And I mean, there are people that actually keep lists and keep it like in their sort of subconscious, but sure. I can't really remember. But we were going for that type of hospital,
yes.
and I mean, Mbekweni certainly isn't the only one like that.
Okay.
I mean, you've got loads of district level hospitals. Which,
so a follow-up question to that is: are there any of your colleagues from that time, when you were doing your Comserve at Mbekweni, who have then found reg posts since then, and do you think that having done that district experience in any way affected their chances of getting reg posts?
Definitely.
Like favorably or unfavorably?
No, so I mean, we've got to be like very open about this and how the system works. Okay. Part of you getting a reg post is your personal excellence and what you bring to the table and your skill set and your knowledge, and part of it is your networking. Networking is incredibly important to get a specialist post, and right now in the environment we're in now with just the absolute scarcity in posts that there are, networking is, I would say, as important as what you bring to the table in terms of your personal skill set. So to get back to what you asked me, you are disadvantaged to some extent by working in a district hospital, but you mustn't let that now completely influence your decision-making process regarding ComServe. But to an extent, your chances are diminished versus someone that was working in an academic hospital where those specialities are present, because they've already become familiar with the department, with the people in the department, with the consultants. They're already on that department's radar for that whole ComServe year.
Yes.
Because they're already expressing interest.
Yes.
Right? So they're already there. And if you come from district, there are certain sort of things that count against you. So you haven't had the academic teaching in rounds every morning, especially if it's a ComServe run hospital.
Sure.
You haven't had that regular exposure to very specific fields, because at Mbakweni we were
Jack
running.
Of all trades, you're doing
100%.
everything.
You're doing. I mean, it was so random. You're running the ED. We made a roster where we rotated through wards just so we had some semblance of order. So Stefan would do males, I would do females, someone would be doing obstetrics, someone would be doing pediatrics, just so that you, for those 2 months, have an area of focus and can sort of teach yourself and learn in those 2 months. But you're a jack of all trades, as you said. And the seniors in the more tertiary facilities and the places where you do apply to specialize regard this as, I don't want to say detrimental. Detrimental is a strong word, but they do see it as a drawback that
Because
you haven't
they
had
are
teaching.
looking at a specialist thing, and they're saying, okay, yes, you did a little bit of let's say we're talking about obstetrics. Yes, you dabbled in obstetrics, but you only did it 2 days a week according to your roster, instead of doing a full 6 months in OBS.
And a full supervised 6 months, because we were not supervised,
Sure.
But that's the point of ComServe. I mean, if we go back to brass tacks and look at what the point is of what the government needs from you, okay? Because this is government service, okay? You're there to serve the government, okay? Internship is for your training and your development, and that's why the hospitals available for internship are, para and all of these tertiary facilities with
Places
lots
with
of teaching,
supervision,
right? ComServe, you're supposed to be out there. You're supposed to go out there and you're supposed to take the knowledge that you gained during internship. And you're supposed to give back, and you need to be, one thing that people forget is you need to be competent at the end of internship. After internship, you need to be self-sufficient and well-functioning and well-rounded. So it's imperative that your mindset during internship as well is, let me gain as much as possible.
Correct.
In terms of, skill set, in terms of academic knowledge, but also like relational, EQ.
Yes.
That all of that is sort of well-rounded.
Professionalism and punctuality, and
that all of that is well-rounded by the time that you're done with those 2 years, so that whatever happens in ComServe, you have a degree of confidence to step into that new facility and be like, cool, I'm gonna be okay because I've done my time,
It's challenging, but the wonderful blessing of internship is that it's 2 years, and it's a structured, like you said, structured, supervised, and there will be bad days along the way.
There'll be terrible days, awful days.
But as long as we chasing progress and not perfection, then by the time we actually get to that MP number, and we're now working in community service,
100%,
we're on the right path. So you did internship, did community service. What then? Because we've got 3 years working in the government sector, and then there's many people who find themselves unemployed at the end of that.
Yes.
So what did you guys do?
Right. So we intentionally decided to be unemployed after ComServe. The narrative is always internship, ComServe, and then jump straight into a speciality. And a lot of people place so much pressure on themselves that they have to identify that specialist field, and the plan needs to be in place. And at the end of ComServe, you need to move right into that MO post, become a reg, and then, chart your way up.
Did you feel that pressure, or
No.
did you intentionally reject that?
I was aware of what the medical fraternity does and what the generally followed route is, but part of me just kicked against that, because you need to be able to make decisions about what's important to you. And I mean, for each person that's different.
And was there anyone in your world who was like, Rob, this is a bad idea? They were trying to talk you into a specialty.
I think when people disagree with me, they often don't say they do because they know that I probably won't take it from them. I don't think I always am the most easy individual to disagree with. So I think while a lot of people might have had that advice from me, they probably wouldn't tell me because my mind was made up already.
Okay.
It's things that you work on. I think on social media as well, like some of the stuff that I post is sometimes very controversial and people end up disagreeing, but they don't engage, which is sad because, engagement is fun.
Do you ever try to poke the bear?
Absolutely. Absolutely. So, I mean, some posts are absolutely there just to sort of antagonize and get a response. And then sometimes it does. There are a few people on my feed who are like headstrong and will call me out and message me and say, look, why are you saying X, Y, and Z? What about this and this and this? And I'll be like, oh, that's a great point. Yeah. So it ends up being a great conversation, and I enjoy that. Yeah. But I think people are sometimes just scared to call out. Anyway, so that's an aside. So with ComServe, we decided what was important to us. And when I say we again, me and Amy, my now wife, decided that we wanted time off. The big priority at that stage was rest, because you've been working for 3 years consecutively.
Because you had done Barra.
Yes.
And then District Hospital, where you did everything. Yeah. I think you earned your rest.
So I mean, with that being said, whether it was at Barra or anywhere else, after internship and ComServe, you as a doctor in South Africa are going to be tired. You're going to need a break. Okay. Some people don't take the break. We said we need a break. The break is the priority, and we're taking the break. So
And when was this now?
This was 2020. 2020. So we finished ComServe in 2019.
Okay. Oh, okay.
And then beginning of 2020, we didn't sign any new contracts. We decided we were getting married, and I mean, I'd love to talk more about that as well. We decided we were getting married, and we decided to then make the honeymoon our traveling as well, and our break. Okay. So we stepped out of ComServe, got married 11th of Jan. And then departed for honeymoon on the 13th of January 2020. And we did 2 months of traveling overseas. And we could.
Yeah.
Because you save during internship and ComServe, you've got a little nest egg, and then you've got no job responsibilities. And when do you actually have that? Never. You'll never have the opportunity to just go off and travel for 2 months.
And you would have been in your late 20s. This is the time now to maximize.
Correct.
You can walk 30,000 steps through the cities, and you can enjoy the sights, and
without checking your phone and wondering when I get back home how many calls do I have to do to make up for the leave that I took. Because one thing about us as doctors is the work that you have to do when you get back is always in your mind.
Yes.
And particularly how leave is structured in many hospitals, that you have to do your overtime. It's problematic because you're never able to completely detach. Anyway, so then that afforded us that opportunity. And when we got back, we said, we're not going to stress about what happens when we get back. We're just going to get back and see what we can do. Should I go on?
Yeah.
Okay.
Because where I'm leading now is, I mean, you currently have a job, and Amy currently has a job.
Yes.
So somewhere between unemployed.
Right. Okay. So we're tying up the links
here.
Yes. And so got back.
You weren't unemployed forever.
No. So we got back from our 2 months of honeymoon / traveling, because that was important to us. We wanted to see the world, and we arrived back just before level 5 lockdown got enforced in South Africa.
Oh, hectic.
So we got off the plane, and the military was there with their thermometers, and 1 week later, level 5 was enforced, and that was when the world shut down.
Sure.
I mean, it's a bit of a distant memory for everyone now, because we're now on the sort of tail end, if I can say that. Take that with a pinch of salt. But where everything was just closed. Travel was just not an option. Borders were closed, and we had just finished our traveling, and then that happened, which made the traveling especially significant for us. Then we had to find jobs, and this is a deeply uncomfortable position, because I think as doctors we're so used to having employment provided. I know now currently not everyone gets placements. Yeah. That's an aside, but generally speaking, your employment is dictated to you. You've got the 2 years set out as interns. You've got the year set out as a ComServe, and those are 3 years of guaranteed employment. Now, for the first time in your life,
you have to go for an interview, and
you're sitting unemployed.
Yeah.
you have to compile a CV, which you haven't done in years,
And for
because there
some
was no
people,
need
they've
for it.
never done before.
And it's deeply uncomfortable because now you have to compile a document sort of advertising yourself, and you have to say why you're good, and you don't really know why you're better than the next doctor because you've all done the same thing. Why am I better than the person who's done the same amount of time as me, who's got the same clinical exposure as me? So it was a very uncomfortable experience trying to do that whole CV process as well. You have to deal with lots of rejection. We spread our CVs quite wide. We're quite creative with where we applied and everything. And I mean, you get a lot of rejection. Well, sometimes you just don't hear.
Yeah.
I mean, but you also do get a lot of rejection letters.
Were you applying in private and public hospitals? So and where were you finding that posts were advertised? Were they advertised on the internet? Were they in magazines? Were they newsletters?
Right.
I mean, do you open the back of the Star newspaper and in the classifieds they say you're looking for ED doctors?
Yeah. So we decided to go with digital advertisements. We primarily use LinkedIn. And LinkedIn is a bit of a mess when it comes to career applications because I feel like you apply for some of them and they just don't sort of go through. It just feels like there's so many applications. Is yours actually being checked? Anyway, but we use LinkedIn, and through LinkedIn and a lot of persistence and a lot of applications, you have to be relentless. You have to be relentless, and you cannot be discouraged. We eventually got into private because the state cycles didn't really lend themselves to getting a post in March, because you have your 2 yearly sort of applications in state. And then, so we eventually found our way into private. I did GP work, and I signed as a partner at a GP practice. Amy got into ED, and she did a long stint in private ED. And I mean, I have a lot to say on that as well. It was incredibly tough for her. It's an incredibly demanding position. Private EDs tend to be businesses. They are businesses at the end of the day, and that means your staffing decisions are also made with that in mind. So she was often the only person on the floor. And when the shift gets busy, the buck stops with you. Yeah. You are responsible for everything that comes into that ED. And if you're working in a busy ED like she did, it's exhausting. And I mean, she did ED shifts 6 days a week, 12 hours a day, for many months. And it was wonderful when eventually we could step out of that and she could go back into state. I thoroughly enjoyed the GP work. I think my personality lends itself to being able to talk to people and discuss, because a lot of being a GP is just having a chat. You know, not this rigidly defined question and answer session, but rather just being able to have a chat with someone and hear what's up. I ended up departing from that post not because of job dissatisfaction, but rather just COVID didn't lend itself to establishing a new practice. Your walk-ins at that stage were so far and few in between because of the lockdowns that it wasn't really viable to continue there. I cast my net a bit wider. I've always had a bit of interest in public health and looked towards research. Was very fortunate to get a research post at Wits, and am very happy there and have been working there now for over a year already.
Oh, tremendous.
Yeah.
Okay, so we've tied the little tails together.
Right.
So we kind of know where you are at currently.
At the moment.
And now I want to bring your social media presence into the conversation. At some point, maybe during COVID, you had this brainwave to start making reels and get a little bit more active on Instagram. Was that an intentional thing of like, I want to be a medfluencer and educator, or was it just a creative outlet during lockdown?
Great. So I think both things you've mentioned there are actually quite pertinent. I think it was a creative outlet as well. I do like making stuff. You know, whether it's clips, whether it's videos, whether it's showing people the new gadget that I got, or giving recommendations on something that I've really enjoyed or that I really enjoy using, or that's a really good product. And then, as you say, there's a part of me that also just enjoys sharing advice and helping people avoid pitfalls and maybe encouraging a little bit. So I think the encouragement also factors into it a lot, because it's quite a negative field often,
Yes.
and we as doctors tend to be very negative overall. And I'm not saying there isn't reason to be. Sure, there's more than enough reason with everything that's happening right now to be negative, but it's not always great when that's the only flavor of the conversation that we have.
Agree
You know?
completely.
And we tend to through being negative all the time really to make that our reality more than it needs to be.
I think what you said there is so pertinent, the way that you say it, our words shape our reality.
Yeah.
Because if we talk about how bad the public health system is,
Yes.
our patients will come in already with that view that they're going to get substandard care, or that things are going to be awful.
Yep.
And so they look at their doctor thinking, this doctor doesn't really care about me, or these nurses aren't doing a good job. And that's why we need to kind of guard and protect
Yes.
our profession, protect.
Yes.
Although we are working in a strained system, although we
Very
are
much.
often working in a resource-limited system,
Yeah.
although we are working in a system where people have unrealistic expectations, oftentimes, they come with a problem that they've had for 5 years and they want it fixed in 3 days and discharge me home, right? And people want to take a pill instead of taking diet advice and exercise programs. And
I mean, what is lifestyle modification?
I just want third line straight away.
100%.
With all of that,
Yeah.
if we are constantly talking about how exhausting calls are and this difficult patients and oh my gosh, the hospital is a mess, we create that reality.
Absolutely. And I mean, you've touched on two important points. And number one, we generate public perspective on the hospitals, okay? Social media is an open book. And the public goes on social media and they see what doctors post.
And because you have DR in front of your name,
Yes.
it gives you an authority.
Yes. And people look at what doctors post. So what doctors speak to on social media is assimilated by the public. Okay. So, I mean, that's another conversation that we need to have about how you need to be very pragmatic, or not pragmatic, very discerning about what you post on social media, because way more people are seeing that information and absorbing that information than what you ever realize.
Yes.
And number two, apart from public perception on facilities, we influence each other's attitudes and how we arrive on shift. What energy are we bringing to shift?
Come on.
And so often that energy is not great because of conversations that we have with each other that are not that positive. Now, I'm not advocating for toxic positivity at all. I'm advocating for measured and practical discussions around what's wrong with the system, but also still keeping each other going. We need to keep each other going.
Yeah.
The system is terrible. It is terrible. Fine, we know this. But we have to keep each other going as well. And if we just speak to negativity the whole time, it's going to be all that's there, and you're going to miss everything else that is potentially valuable and good about the job. Because there is still good stuff. All the negative stuff doesn't take away the positives of your job.
I think shared experience is so valuable because every donkey feels that their load is the heaviest, right? So everyone thinks they're the only one going through these tough calls and feeling exhausted and their
100%.
feet hurt and I haven't had a wee in 6 hours.
Yeah.
But when you talk with your colleagues and you realize that we're all in this together, hopefully that builds some kind of cohesion, builds some kind of, I don't know if it's shared trauma or what, but we should unite around this to build one another up, like you say, to strengthen one another up.
Yeah.
And anyone can point out faults. But when you decide to unite to come up with solutions, you'll be amazed at what you can do, even if it's as simple as reorganizing the ward stockroom so that you can find what you need. You might be surprised. There's tons of pink and blue gel codes behind those boxes.
Yeah, or, under the linen savers, no, exactly.
Okay, so that's kind of where I wanted to go with Instagram and social media. Were you surprised at how quickly you gained followers? Because you have thousands of people tuning in now.
So, I think my situation is maybe not the most organic growth either. You read online about what you should do with your account, and a lot of people say, or everyone really says, you need to find your niche.
Okay.
And for me, it's been a particular challenge finding a niche because, sure, medicine is one part of me and one aspect of my life, but it's not the only aspect of my life, and now to have an account that's exclusively medicine is also just like, a bit difficult for me because
Yeah,
there's
but
so many.
yours isn't exclusive.
No, it's not.
There's coffee, there's dogs, you're CrossFit now.
Yeah. So the reels came about as me being a bit of a prankster. I've always loved being a bit of like a practical joker and a prankster. And you don't find an outlet for that in adult life much because everything is just very serious.
And people get so sensitive when they're the butt of a joke.
Yeah, so I mean, the reels are a bit of like just a bit of fun and a bit of an outlet. And I mean, if you manage to go viral with one of your reels, you tend to get followers quickly. The issue with that though is it's not organic growth.
Okay.
It's one sort of takeoff item that then generates a lot of followers who are not necessarily tuned into exactly what your brand is. So I mean, part of this is organic growth. Part of it, I think, is one or two reels that have gone viral. But I mean, at the end of the day, I guess you mustn't overthink it too much, and you've kind of just got to keep posting what you want to post as opposed
your
to
account.
as opposed to what you think people want. But it can be quite time consuming.
Yes.
Running something like this, and you often just have to gauge, is the time coming from your day spent investing in this worth the time that you could have been spending with person
With your
X, Y, and
spouse,
Z, with your spouse, going out for walks in the park with
Has
your
it
dogs.
ever generated tensions?
Definitely. I mean,
And then what do you do? Just pull back a bit for a couple of weeks?
yeah, so you have to reassess. And I mean, like I said before, I'm maybe not the best person at taking criticism either. So hearing from your spouse that you're on your phone a lot is and when it's true, it's even more difficult to sort of accept it. Then you've got to kind of reassess and be like, cool, this is maybe a problem, and I do need to maybe define more rigidly times of the day when I'm generating content and planning content and when I'm responding to things.
But I don't think that's only limited to your experience with social media. It can be anything.
Yes.
Somebody could have an obsessive Lego building habit, and
No, fine.
somebody will say, "Can you please just put the bricks down? They're made for 8-year-olds." So we have seen over the last few weeks, you've been posting a little bit more about internship and junior doctor time.
Yeah.
One of the themes that came up was about the dangers of glamorizing medicine as a career. Now, I think being in medicine, you know a lot more than the general public, and the general public has some misconceptions based on Hollywood rendering and the appetite that the general public has for drama, medical dramas and things, does make the shows a little bit fanciful and not true to life. I mean, when we watch medical dramas, we're like, no, that's not true. That wouldn't happen. You wouldn't have, a show like New Amsterdam. The paramedics crash through the doors and they're already telling you the handover, and the first person at the scene is the cardiothoracic surgeon. And what's he doing in the ED? So what do you think about this whole topic of glamorizing medicine as a career choice? You mentioned that as a doctor, you like to teach, you like to educate. We know that the word doctor comes from docere, to teach. What can we do to rightly frame medicine as a career? I think I'm being a little bit all over with this question. So
I think I understand the flavor of what you're asking, though, and I'm going to do my best to sort of address the various little points that you've mentioned now.
I don't want to throw too much at you because this is just something that has come up, and I think you've started the conversation
right
and put it on the wall for others to add their little points.
Right. So I mean, let's start with just what you first spoke about, and that's glamorizing medicine. And I think it's a job as well. It's a deeply meaningful job. It's a rewarding job, but it's a job. And I think part of the whole issue that we have is that people confuse being a doctor with their identity. It is part of, I guess, to some extent, of who you are, because you are serving people and you enjoy medicine, but it doesn't change the fact that you're still a person. And I think medicine has sort of been glamorized because traditionally, I've got to really be careful how I phrase this, but traditionally, sometimes doctors have regarded themselves as being of an elevated position in society based on the profession. And such thinking and such notions are very dangerous because your inherent worth as an individual isn't more based on your job, okay? And I think so many doctors have perhaps had this notion of inherent worth being higher just based on profession, that they've sort of portrayed this as the thing to do, and the public has latched onto that. Now, I mean, I can't reference specific historical events where this has happened, but I mean, if you look back, let's say 50 years, doctors were the authority, and you would never question a doctor, and that the doctor says goes, and so on. And
But even it happens now in advertising. 9 out of 10 dentists agree that this is the best toothpaste.
Right. Fortunately now I think the public's a bit more informed, and they know that doctors are normal humans with their own set of issues that they have to grapple with. We're not some different, class. And that glamorizing, that notion of medicine being the pinnacle, I think came sort of from that. It's like I said, it's a profession. There's a lot of value in it, but it's still a profession, and nothing makes it more important than any other profession. And it's a difficult job. It's an exhausting job. The hours are not ideal, and there's a lot of personal cost. And the only way that you sort of get a real idea of what medicine is, and you see through that veneer, sadly for us, I think, is once you're actually working in internship.
Yes.
You have no concept of what it costs to be a doctor until you've started working as a doctor. And I don't think even job shadowing could give that to you, because you only spend a day or two doing job shadowing. It doesn't speak to the week or the month in that rotation.
And the doctor wants to obviously put their best foot forward during the day.
Right.
We all at our hearts have a slightly narcissistic streak.
Yes.
We post our best moments, our best selfie on social media.
Absolutely. And social media draws that out. 100%. Yeah. So I think to say how you would orientate yourself and get a good idea of what medicine is like, there isn't really a way until you've actually been working in it. But what you're doing here with this platform, and perhaps chatting to people, getting just candid views on the field, is a great way to do it.
And a variety of, because
that's important. That's important.
To get people one-on-one where they don't have departmental pressures.
Right.
They don't have their peers kind of like looking, whoa, what are you saying there?
Absolutely.
Where they're open to share their view. And it is, I mean, all of the specialists that we've had on, their views are separate from their departmental roles, and teaching roles. It's their experience, it's their path in medicine.
And what you've mentioned here is crucially important. And I'm going to go back to internship and ComServe now as well.
Sure.
You've said multiple perspectives. You need to talk to more than one person. My views are not universally true and not universally correct. I have my view and my experiences. So you need to get advice and perspective from lots of different people. Do the work of talking to different people. And then from all of those opinions that you've gotten and those views that you've gotten, you can then make your own.
Yes.
You can make your own conclusions.
So our previous guests on this podcast have all been specialists. And one of the goals of this podcast was to unpack what the specialities are about, the road, when to do primaries, what diplomas will gain you an advantage to get a reg post that. And I mentioned that I kind of see you as the anti-specialist, and that's a bit of an unfair moniker. So, sorry for that. But
you and other people, I've heard it before.
You've been outspoken in saying that you don't have to specialize.
Yes.
Even though everyone says, what are you going to specialize in? That's the wrong approach.
Yeah.
So what are your views? I mean, are you interested in specializing one day? Or are you just kind of on pause for now?
Yeah.
What's your view there?
Great. And I mean, I love that you've brought up the word anti-specialist. Many people on social media have gone into my DMs and said, yes, Rob, what's wrong with you? Are you anti-specialist? Why are you so against specializing? And I think, in fairness, I'm not opposed to specializing. I think the view of specializing is so commonly held as the only career trajectory that doctors have, that when someone speaks out often about there being other career paths and specializing not being the only way, it seems as if they're anti-specialist, when in fact they're just speaking to the fact that there is another route. There are other options available. And this is the reality. As an intern, for 2 years, you are taught by specialists.
Only specialists. Yeah.
Only specialists and registrars. Okay. As a ComServe, if you're in a tertiary facility, you are taught by only specialists. You are never, in your 3 years, taught by researchers. You are never taught by GPs. You are never given alternative life exposure other than that of a specialist. And I feel it's just very important to speak to the fact that there's something else out there. There's alternative routes. And I like to sometimes kick against what is held as conventional.
Is it that prankster mentality?
I think so. I think it's that sort of dynamic.
It's your natural gifting.
Yeah.
You spot something that you want to see, you want to push the boundaries and say, like, is this a firmly established thing and why?
Precisely. And when you have so many people around you and you just see them suffering under the pressure of having to carve out a very narrow career in medicine, and this was sort of put onto them by the fraternity, you kind of like, listen, there's another way.
And having to make a decision, sorry to cut you off, having to make a decision at age 27, 28 about what you're going to do for the next 50 years.
Exactly. So I don't like seeing people pressured and forced into a narrow lane and not being aware of anything else. You have to speak to the fact that there's other options. And I mean, I am an absolute lover of anesthetics and psychiatry. Those were my two
slightly two different roles, because one they're very much asleep and one they're very much awake.
Yes, precisely. Like two opposite ends, you know. And those two fields for me are spectacular. I love them to bits, and I genuinely entertained specializing in either of those two at a stage. But you know, like we've been speaking about, it's about what's personally important to you as well, what your goals are and what your priorities are in life at the space that you're in. And I mean, you do the sums, you have the conversations, and the commitment is great. So if you're going to jump into something like that, you need to be well versed in what you're signing up for. And I mean, as we've said, the only way you know that is by speaking to people. Yeah. So I mean, just to summarize a bit, I would say definitely not anti-specialist, but also very pro speaking to other fields being out there, other career paths being out there as well. Yeah.
So, okay, now I want you to be the big brother and give some advice to junior doctors that are coming after. Yeah. Maybe some leading questions to think about. If you go back to your junior doctor days, what would you have changed about the way that you did internship?
Right. It's difficult to reflect on 2 years and to identify isolated things that you would change. I think probably then saying what are specific events that I would change, I'd probably maybe speak to mindset. Mm-hmm. I would love to have imparted the knowledge early on that it's not just about academics. Mm-hmm.
Imparted to yourself?
To myself, okay. To myself or to anyone who's currently stepping into internship. Sure. It's not just about the academics and the medical skill alone. Okay. Holistic development is so important. Sure. And we tend to completely neglect holistic development. Our other spheres of the you-ness that is you know, get completely sort of put by the wayside simply to serve your job.
So what were some of the things that you put on hold that you, in hindsight, you're like, gosh, I should have done more?
I mean, just developing creative outlets and hobbies, and activities for rest in general, because these are sometimes things that you don't just have; they're also things that you learn, you know, and that you have to develop. And I think a lot of us just don't learn what we love to do in our free time because we never have free time. So fine, that's not a practical thing that you don't necessarily have time, but be cognizant in that time already of the fact that you're a multifaceted human and that there's a lot of you beyond medicine that needs feeding. Because once you're done with internship and ComServe, you're going to have a lot more time with yourself. There's not going to be the job to occupy your every waking moment. And it gets uncomfortable when...
Music around us is so suspenseful.
Yeah. And you know, not having that job occupying 24 hours of your day
Yeah.
leaves you sometimes very uncomfortable, realizing that you're not as developed as you thought you were.
Sure.
There's deficiencies. There's a lot of deficiencies.
Yeah.
And I think I would love to speak to my younger self about that and just change the mindset,
Yeah.
you know?
Terrific answer. I think that's great. What was a big deal for you during your junior years? Was there any event or anything that you can think of that seemed like such a big deal that now in hindsight, wasn't a stretch?
So how people treat you,
Okay.
because we tend to internalize or take to heart a lot how seniors treat us, because we regard seniors as the people. Because it doesn't matter at that point. You're not thinking about what's this person going through. Did they have a bad day? Are they struggling with their studies? Did the consultant chew them out?
Yeah.
You just receive behavior from them, which is sometimes negative, and then you think that you're a terrible person and you've done a terrible job, and you hit rock bottom because of those things, whatever, or behaviors that are exhibited to you, and it isn't such a big deal. Retrospectively now, you realize humans have bad days, and you shouldn't take to heart necessarily when someone reactively responds to you or says something mean to you. Let that be water off your back.
Yeah,
You
I
know?
think that's such a terrific answer, and
Yeah.
and that correction and the way that we respond to correction is part of character development. It's part of learning as an intern. I think it's also important for our seniors to learn how to correct without condemning someone.
Sure.
In language and body language and things like that. And how to maybe also to humble somebody without humiliating them.
Precisely,
Somebody does need to be reined in a little bit. But it's a sense of maturity that we need to develop, that we understand. I think it comes back to what you were saying earlier, where being a doctor is not our end all and be all. It's not all of our identity.
Exactly.
That we realize that we are more as human beings than just our profession.
Yeah, and I mean, I love that you've touched on correction as well, because you aren't going to be perfect as an intern. The whole point of the entire 2 years is for you to learn, okay? And the mindset needs to change from being a perfect medical student, getting the grades and doing well in every test and assessment, and the consultants being so happy with you as a student, to I am now in a brand new environment and I'm learning. So if a registrar or another doctor or a consultant corrects me, that's great, because it means that I'm learning something that I didn't know before. So the correction shouldn't be seen as you being a failure. It should be seen as being part of internship, because that's your 2 years.
That's so good.
Yeah.
Okay, so do you have any top tips or tricks? Was Rob known for anything particular during internship? I don't know if it was pranks, but did you have any special techniques for finding that elusive vein that wants to jump out the way?
Oh, right. Right.
It doesn't have to be putting in drips.
Yeah. I wouldn't say I was particularly gifted at any clinical skill. I would say probably, I guess this still feeds into being advice.
Yeah.
Sometimes it's okay to be lighthearted. You know, you're allowed to not be serious sometimes, and you shouldn't take yourself too seriously. And I tried to on the days that I wasn't, into call 32 hours, where I had a bit of rest, to be a little more lighthearted, to be a little friendlier. From time to time, you're allowed to make jokes with patients. They enjoy that as well. Your interactions don't all have to be serious and somber and solemn.
Yes. No, wonderful.
You're a human,
Correct.
okay? And patients also want to be, or rather want to forget sometimes that they're in the hospital by just having a good chat with another human.
Yeah.
So allow yourself to be a bit candid sometimes, to be a bit frivolous sometimes. And don't take yourself too seriously, because I think a big problem with doctors in general is we take ourselves too seriously. And
it comes from the heart of wanting to do well by our patients, and wanting to not be corrected for making mistakes and all of that. Just thinking on this, one of the funny things that I do with patients that have difficult veins, when the tourniquet is on and you're looking for a vein, let's say I've poked the patient now and I've struggled to get a lineup.
Yeah.
I'll say to the patient, my dear, it's okay. You can either have good veins or a good personality, but not both. And then the patient feels like I'm a good person. There,
Absolutely.
Just little
Absolutely.
things like
Yes.
that, where
And
you
that's
just put people
uplifting.
put people in.
And my conversation starter is always, so I actually have a phobia of needles.
What?
Yeah. So,
Do you have any tattoos?
no.
Okay. Because of the fear of needles?
Yeah, largely. Largely. I mean, I've been entertaining the idea of getting a tattoo for a while. And I mean, you'll see my Instagram messages as well. My one friend has the most gorgeous tattoos, and I've been asking him a lot about it. And the conversation always ends up with the needle,
Yeah.
and how sore it is. And then it ends there, And whenever I'm drawing blood from patients, I'll always relate to them how scared I am of needles. And then they're absolutely shocked, But I mean, this is not just me.
Well, at least the needle's pointing the other way.
So precisely. So I tell them, look, I'm generally okay when it's pointing the other way, but when it's pointing at me, I mean, it's literally like I don't know what to call it, like a vasovagal response where I get cold, I get sweaty, and I often faint.
What?
Yeah. So it's a crippling fear, and I'll often just relate that tale to patients and tell them, look, I mean, you're doing a lot better than I would have been under the same circumstances. So yeah, I mean, it's reached the point where I only allow my wife to draw blood on me because I don't trust anyone else to do it.
That's so interesting.
And even when she does, she has to hold my hand and
mop your brow.
Yeah. with a cold perspiration running down your forehead. So I'm a big baby when it comes to that. Yeah.
Okay.
Yeah.
Final part. This has been a really, really fun episode. It's been a little bit more lighthearted and jokey than usual, which is great. I think the podcast badly needs it. I think medicine needs it. I think we all need it.
Right.
So here's some quick fire questions.
Yeah.
Just the first thing that comes into your mind, okay?
Sure.
NGT or lumbar puncture? To do what?
NGT.
Casualty or clinic?
Clinic.
Weeknight call or weekend call?
Weeknight.
Rugby or cricket?
Rugby.
Locum or owning your own practice?
Locum.
Surgery or internal medicine?
Surgery.
And then final thing, to not eat the whole call or to not drink the whole call?
To not drink the whole call.
So you'd rather eat but not drink?
Absolutely.
Yeah.
I love food too much.
Well, you did very well. I think you passed. You got full marks for that still. But thank you so much for agreeing to be on the podcast.
Yeah.
I think that's just through candid answers and just you being on the podcast, you have answered a lot of questions that people would have. People might not even have known the questions that they would like to get answers to. And when you share your experience and you share the decision-making process, I think that you're going to help a lot of people. So thank you so much for speaking out to our audience, sacrificing your Saturday morning to be here. I really appreciate it. Thank you, Dr. Rob.
And I mean, thanks for the platform. Stuff like this is so important, just chatting around issues like this. And I would encourage anyone who listens to this to message Dr. Coffee, with additional questions. We love engagement. Our accounts are built around engagement, and I think for us it's so fulfilling to engage with you. So please do message out to Dr. Coffee if you're wondering about anything, or if you perhaps have ideas for another podcast.
I hope you enjoyed this week's episode as much as I did. If you know of a consultant or senior registrar in a specialty that you would like featured on the Dr. Coffee podcast, please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks. We're also on Instagram and YouTube with the username @drcoffeeza. If you've got anything else on your mind, such as a request for additional topics, further information on how to engage with our guests, feedback on the show, or anything else, please get in touch. We'd love to hear from you. The Dr. Coffee podcast is brand new, with freshly brewed new episodes each week on Apple Podcasts and Spotify. Please consider sharing this episode with fellow junior doctors and medical students in your world who you think would benefit from the content and enjoy. Thank you so much for your support.